Welcome everyone to our webinar, Understanding the Relationship Between Fear of Falling and Mobility in Older Adults, facilitated by the Fall Prevention Community of Practice. My name is Mariel Ang, and I am the Project Coordinator at the Ontario Neurotrauma Foundation. ONF sponsors the Fall Prevention Community of Practice and its online platform called Loop. Loop is a place where fall prevention practitioners connect. Visit us at www.fallsloop.com. Marguerite Thomas also joins us on the line. Marguerite is the liaison for the Fall Prevention Community of Practice. She will be assisting with facilitating questions in the chat box today. Before we begin, I'm going to give you a quick rundown on the Level 3 meeting system. The webinar technology consists of two parts. The audio is provided through a telephone conference line, and the visuals are provided through a web platform. The phone number for the conference line and the link to the web platform were sent to you by email after you registered for the webinar through Level 3. If you have any questions about the technology at any time during this presentation, please type them into the chat box on the left-hand side of your screen. Alternatively, you can email me at mariel@onf.org, and I will work with you to resolve technical issues as soon as possible. If you have a topic-related question during the presentation, please type them into the chat box. During the Q&A, we will read the questions aloud to the group. If you prefer to ask your question over the phone, we will provide you with instructions on how to unmute your line during the Q&A. The webinar is being recorded, and a YouTube link will be sent to all participants in about 1 week along with the presentation slides. I would now like to introduce our presenter, Dr. Mohammed Owais. Dr. Mohammed Owais is an assistant professor in the School of Rehabilitation Therapy at Queen's University and a licensed physical therapist in Ontario with expertise in musculoskeletal and geriatric rehabilitation. Following his PhD in rehabilitation science at McGill University, he completed 2 postdoctoral fellowships at Western University and Queen's University, funded respectively by MITACS and the Canadian Institutes of Health Research. Mohammed's research aims to increase the understanding of how modifiable risk factors interact to influence the mobility of older adults, specifically those with hip fractures, and how to integrate this knowledge into rehabilitation. His ultimate aim is to bridge the gap between actual practices and optimal care, eventually leading to better health services and patient outcomes. It's a great biography, and so without further ado, please take it away, Mohammed. I will be unmuting you in just a moment.
Thank you, Marielle, and welcome everyone. It is my pleasure to be here with you today and discuss with you fear of falling and its management. Without any further ado, I would like to share with you my plan for the webinar today. So I divided the webinar into 3 major sections. The first section will be on background on fear of falling. Then I will share with you some research we have done on fear of falling and its relationship with mobility in general using different measures. And I will end up the webinar talking about some evidence-based interventions that people at the front line working with older adults could use to improve fear of falling. Before I start talking about fear of falling, I would like to share with you a personal story happened with me a few years ago, which increased my interest in this topic. On a cold night in the fall of 2012, I was walking back to my office. I forgot something, and my office was at the Royal Victoria Hospital at the time. In my way to my office, I noticed an old lady holding on to a street light at the edge of the road. That was a little bit strange, but I didn't pay a lot of attention to that. In my way back, about like 25 minutes later, I was walking back the same way, and I was shocked to see the same lady in the same position. I asked her if she needed help, and I ended up lending her a hand to help her reach her house, which practically was about like 15 to 20 meters away from where she was standing. What really puzzled me is that like she really didn't need to help her physically. Like I didn't help her physically to go walk these 15, 20 meters. I just provided some confidence assurance to her. After all, she had been standing all this time on her feet. So physically, she was more than fine to walk that short distance. So this incident left me with many questions, like why that happened. Was she afraid of falling due to a previous devastating fall? Was she afraid of walking because the ground there was some ice on the ground? It was November as far as I remember. Really, this story resonated with previous observations from my physiotherapy career, and I didn't think that was an isolated case. And that was my first experience with what I will later know that it's called fear of falling. So this incident increased my interest in this topic, and I ended up researching this topic and how fear of falling, which is an emotion, could influence mobility for older adults. Before I started to share with you some definitions and terminology of fear of falling, I have a quick questions for you. So for those of you who practice in a clinical setting, do you evaluate fear of falling in your clinical setting? And not necessarily you, like yourself, like if you evaluate fear of falling in your institution, please answer yes, otherwise no, or not sure. So I'll give you a few seconds to finish. Okay, so I still see some people still providing answers. I'll be closing the poll in a few seconds. Okay, so the poll is closed now, and so like 46% do evaluate fear of falling in their clinical settings, which is very good actually. 41 don't do that, and about 12%, a little bit more than 12%, they are not sure if fear of falling is being evaluated in their settings or no. And this is interesting. So we have some people who have experience with the fear of falling evaluation, and that will be helpful later on when we speak about ways to evaluate that. So in my first section of this webinar, I would like to briefly talk about fear of falling, and just to make sure everyone is on the same page. So this is one of the simple definitions of fear of falling that I like to use. This definition was provided by Mary Tinity early in the 90s, and she defined fear of falling as a lasting concern about falling that leads an individual to avoid activities that he or she remains capable of performing. And this fear contributes to the probability of more falls. And there's one key thing in this definition, which is that fear avoid doing activities that the individual physically able to do. And I think this is a key in this definition. Now let me share with you some statistics about fear of falling. As you know, or at least the majority of you know, fear of falling is common among older adults. It depends on the study and the population they are investigating, the tools they are using, the cutoff points they are using, the range of the prevalence of fear of falling among older adults, 65 and above, is between 25 to 85%, which is high. Among those who report having fear of falling, 20% to 55% reported curtailing their physical activities as a result of their concern. If you think about it, that's a lot. So up to 1 out of 2, up to 50% curtail some physical activities as a result of their fear. What's interesting about fear of falling is that it's much more common among those who had a fall before, but it's not limited to them. So we know that some people who didn't have a recent fall, they also report fear of falling. And what's interesting, a recent study published recently, they found that, so they were, in that study, they were investigating factors to predict future falls, and they found that the factors could predict future falls actually differed based on the number of falls people had recently. And they found among those who didn't have a fall in the last year, in the last 12 months, fear of falling was the most important factor to predict future falls. So for this subgroup of older adults who report fear of falling without having a recent fall, actually this is a red flag and a very important sign that these patients are at high risk and something needs to be done with them. Now, if you are wondering if fear of falling is really that important and if people should pay attention to that, I would like to share with you this snapshot from a very recent paper, practically was published 2 weeks ago. So this paper from UK, a group of researchers wanted to create a list of the top 10 research priorities for older adults with comorbidities. So they consulted with more than 300 persons, including older adults, caregivers, healthcare providers, researchers, social workers, and they used a very strict methodology to come up with top 10 priorities. So they started with, like, people suggested over 90 research priorities. They shortlisted that into 20, I guess, if I remember correctly, and then they ended up with a list of the top 10 research priorities for older adults with comorbidities. And for my surprise, fear of falling, investigating and searching fear of falling was among the top 10 priorities as identified by all these stakeholders. So, overall, there's increasing interest in fear of falling and what to do with patients who have fear of falling. Now, fear of falling is really important, and we know from the literature that fear of falling has been associated with an array of negative outcomes. I have a list here of some common negative consequences associated with fear of falling, but this is not an exhaustive list. So in the literature, you'll find that fear of falling has been linked to decreased muscle strength and physical capacity, social isolation, falls, greater frailty, higher risk of ADL disabilities, and even increased mortality. So yeah, fear of falling is a big deal, and we need to pay a little bit more attention to fear of falling and how to manage it. Now, since we are talking about these negative consequences, it's very common in the literature to say that fear of falling is linked to falls and disability. What we are not sure about is how fear of falling could be could lead to disability and more falls. Traditionally, researchers have believed that fear of falling could lead to a vicious cycle beginning with self-imposed reduction in physical activities. Then that could lead to poor balance and slower gait speed, which could lead to falls, and falls could lead to functional disability. I should say that we don't have enough strong evidence to support this, but this is the most common explanation for how fear of falling could lead to disability and falls. And keep in mind, this will not happen in a week or two. This happens over years. So that takes time to happen. There are in the literature some other suggestions, like some other suggested mechanisms to explain how fear of falling could lead to falls. But again, this is something that needs further research. I would like to share with you also the terminology you might see when you read about fear of falling. So there are different terms could be used and that people use in the literature to talk about the psychological effect of falls. And sometimes people use these terms interchangeably. One of the early definitions or terms that was used to describe like extreme fear of falling was to phobia. And as you can see, some researchers thought that fear of falling should be categorized as one of the phobias. If I remember correctly, that paper came in 1982, and they described like a small group of patients who had that very severe fear of falling. But people didn't use this terminology, so you rarely see that anymore in the literature. Another term came after that was the post-fall syndrome, and people didn't use that a lot as well. Now, part of the problem with this term is that, as we discussed, fear of falling is more common among those who had a fall, but also you can see it among older adults who didn't have a recent fall. However, the most common definitions you will see in the literatures are fear of falling. By far, fear of falling is still the most common term people use to describe like the psychological effects after a fall or related to falling. You will see a lot falls efficacy being used and balance efficacy. Today I will not be talking about the differences between this. I just would like to highlight that there's this discussion in the literature because some researchers traditionally used to use these terms interchangeably. And in the next slide, I will show you some measurement tools, and I will show you that sometimes the measurement tool describe measuring falls efficacy, but if you look at the actual items, it actually evaluates fear of falling, not efficacy. So traditionally, people used to think that these are the same thing. Now, more and more researchers are saying, no, they are different. Fear of falling is an emotion versus falls efficacy is a cognitive perception of abilities. Same thing for balance efficacy. We will not be discussing that today, but just be aware that this discussion is happening, and this is something we need more evidence to make sure. Some researchers say that fear of falling is an umbrella term that cover many other constructs under fear of falling. However, like I always say, for clinicians, you don't need to really worry about that, as long because these terms, even if they are different, they are highly related to each other. And whether you measure fear of falling or falls efficacy, you shouldn't be too worried about that. They are highly connected. And the most important thing is to do something about this fear of falling or falls efficacy or balance efficacy. So in this table, I have some, from my point of view, the most common evaluation tools for fear of falling and falls efficacy. And although I don't want you to focus a lot on the difference between falls efficacy and fear of falling, I did split these measures into two categories, falls efficacy on my right and fear of falling on my left. So under the falls efficacy and balance efficacy, the fall efficacy scale, perhaps the most commonly used measure of falls efficacy. It was created by Mary Tinnity from the United States. I guess, if I remember correctly, it was published in 1990 or early 90s. And since then, there were a few revisions and modifications were created based on that to improve the ability to measure falls efficacy. One of the common ones to measure balance efficacy is the ABC, Activity-Specific Balance Confidence Scale, in which you ask the patient to give a percentage how confident they are about doing specific activities. On the other side, the fear of falling common measures. Traditionally, researchers used to use a single item question to measure fear of falling. And that could be as simple as asking the elderly person, are you afraid of falling? And the answer could be yes or no. And there are some studies use that simple measure. Some people, one of the critiques for this, there are two problems with single item questions. One of them, there's not enough reliability and validity testing have been done to validate the single item questions. However, they have been used, and some people like them. They are quick, easy, simple. The other critique for single item questions that you can differentiate between those who have high fear of falling versus low fear of falling. So to go around that problem, you find some researchers still use the single item questions, but they added, instead of yes, no answer, they have a scale from 0 to 4, 0 to 10, and they ask the patient to give a number for their fear of falling from 0 to 10. Again, it's very useful in clinical settings. In terms of research, there are some questions about the reliability and validity of these measures. The SAFE also is commonly used. One of the advantages of the SAFE is not only evaluating fear of falling, but also activity avoidance. So the avoidance of daily life activities as a result of fear of falling. I would like to highlight the Fall Efficacy Scale International. So as the name could tell you, so the Fall Efficacy Scale International is a modification of the Fall Efficacy Scale, the original Fall Efficacy Scale. But this is listed under the false efficacy measures, and the international version is under the fear of falling. And the reason of that, although the name here talk about false efficacy, if you look at the actual questions, they are actually about the concern. In the next slide, I will have the items of the short version of this scale, and basically they ask the patient to evaluate their concern about falling, their fear of falling. This is one of the things you see in the literature. So the single item questions usually talk about the fear of falling. Some researchers said fear is a very strong emotion, and it might not be the best word to use here. So people use other terms like, are you worried about falling? Do you have concerns about falling when you do this activity? So lots of measures available. I have here a link for a review that was done by Jorstad et al. In Europe, and they reviewed all the available measures for fear of falling and fall efficacy. They found, it was published in 2005. Despite that, they found more than 23 measurement tools. And since then, I'm sure we have much more. So there are lots of them. As long as you understand what you are measuring with that measurement tool, many of them actually have been validated and used. Personally, I use the Fall Efficacy Scale International simply because I will be in the second section. I will be sharing some of the results for you, but because this was created with the idea to be used in different contexts, different environments, and that's why it's called international, and it has been validated in, I can't remember, it has been translated into more than 20 languages maybe. They have their own website, and you can find all the details on that website. So many measures, just be sure which measure you are using. I would like to share with you the short version of the Fall Efficacy Scale International. So in order to facilitate the use of this measurement tool in clinical settings, the original scale includes 16 questions, 16 items, and that takes between 10 to 15 minutes to complete. It depends on the person and the setting. So the people who created this tool decided to create a shorter version, and it's called the Fall Efficacy Scale International short version. And these are the questions they ask about, the activities they ask about. I didn't include the sentences you need to read for the patient. They are a bit long, but basically they ask the patient or the participant to what extent you are concerned about falling when you do any of these following activities. And they ask them the first, second, up to 7. You end up, the option answers are, I'm not concerned at all about falling when I do each one of these specific activities, somewhat concerned, fairly concerned, very concerned. The questionnaire ends up with a score from 7 to 28. The higher the score, the more fear the person has. And again, this is just an example. In my research, which I will be sharing with you in a few seconds, I used the full version of this, and I found it, because I used international data in my studies, so that was a good option for me. Okay, so another question for you. For those who, the 46% who responded by yes to the previous question, that they use any one of the fear of falling assessment tools, would you choose which tool you use in your clinical setting? So do you use a single item question? Do you use the SAFE? Do you use the concern about falling scale? Do you use the fall efficacy scale international? Do you use the fall efficacy scale, the original one or one of its modifications? Again, I separated the international from the other one because they separate a little bit two different things. They measure two different things, fear of falling versus fall efficacy. I'll give you a few seconds to think about that question, and then I will close the poll. For those who, I see quite a bit, about 20% choose others, would you write, if you would please, could you just write in the chat box the other tool you use in your clinical setting? Thank you for all of those who provided answers. I will close the poll after a few seconds. Now, just a reminder, if you are interested in seeing like which tool to use and if you are, which tool is reliable and valid, etc., the review I referred to in the previous slide or two slides that was published in 2005. It's a bit old, like it's not very recent, but it has a lot of information about the majority of the tools people use usually. And they have a table, very nice table, in which they have the tool and if it's like what extent it's valid, to what extent it's reliable. So they have all that information in one or two tables. So I usually find it very helpful. So feel free to check that publication, that review. Okay, so I close the poll right now. And interestingly, single item questions, and that might be completely fine. So it depends on your setting. I always suggest, like, when people ask me about like what to use, which one to use in your clinical setting, I say you could start with a single item question. And if the answer for that question indicates that the person have high fear of falling, then you can go and use like one of these long questionnaires. You don't need to use like long questionnaires with everyone. For fall prevention clinics, I highly recommend using like one of these reliable questionnaires, simply because they are validated, reliable, and very useful. And I will share with you some of the results about like to what extent we found fear of falling could be associated and predict other outcomes. So thank you for everyone shared the tool they use in their clinical setting. Now I would like to share with you some of the results we have done about fear of falling and mobility. And I will be talking about specifically 3 studies. The first one about fear of falling and mobility disability, fear of falling and life space mobility, and finally about fear of falling and incidence, so the onset of a new functional disability. Before I talk about the specific studies, I would like to talk about these 3 studies happened under the umbrella of the International Mobility in Aging Study. For those who are not familiar with International Mobility in Aging Study, which I will be referring to as AMIAS for the rest of the presentation, it's a cohort study examining the various factors related to mobility of community-dwelling older adults. At the baseline, all recruited participants were 65 to 74 years old. This is an international study. If you remember, like I mentioned, the Falls Efficacy Scale International was good for me because I use data in international setting. So this is the study in which I used the FESI. We recruited 2,000 older adults, 65 to 74 at the time of recruitment, from 5 sites, 2 in Canada, Kingston, Ontario, and St. Hyacinthe, Quebec, 2 in Latin America, Natal, Brazil, and Manizales, Colombia, and 1 in Eastern Europe, Tirana, Albania. Participants, older adults, were recruited from the community at 2012. The first follow-up was 2 years later, 2014, and the final follow-up was in 2016. And the study was funded by the Canadian Institutes of Health Research. I will not talk a lot about AMIAS, but if you are interested in knowing more about AMIAS, maybe they have like 70 publications from that study right now or so. Yeah, feel free to check there. This is a snapshot from their website, and it got a lot of information. But I just wanted to say that this is the study we used to do all the 3 studies I will be talking about very briefly in the coming few minutes. So in the study that I will be talking about, I used AMIAS data 2012 for the first 2 studies, and for the third one I will be talking about, I used 12 and 14 data. I mentioned that already. For evaluating fear of falling, we used the Falls Efficacy Scale International. It got 16 items, 16 questions, and the final score could be 16, which is no fear of falling, to 64, which is the maximum fear of falling. In AMIAS, for these studies I will be presenting, I excluded those with dementia. So let's talk about the first study, which is fear of falling and mobility disability. So the aim of this study was to examine if fear of falling is a risk factor for mobility disability after adjusting for other confounders among community-dwelling older adults from 5 different sites. And let me talk very quickly about the outcome here, mobility disability, since people might use this term meaning different things. So in AMIAS and in other studies, mobility disability is typically defined as a self-reported inability to walk 400 meters or to go up 1 flight of stairs without assistance. So if the elderly person reports he's unable to do either one of these 2, walking 400 meters or 1 flight of stairs, that is the operational definition of mobility disability. And why it's important, in the literature you find them talking about mobility disability as a preclinical stage of more than half of end-stage disabilities, in which patients end up not being able to do the basic ADL activities. What we know about mobility disability is that it's preventable and amenable to interventions. So if we can catch people at that stage before they transit to being fully disabled, we can actually reverse that. That's why people are interested in mobility disability. So understanding any potential relationship between fear of falling and mobility disability could provide a basis for screening those at risk and intervening before transition to end-stage disability. So this is the outcome we used in this study, and I will save you the details of methods and analysis. You can go to the paper if you're interested in these, and just share with you some of the results, highlight some of the results. So this is descriptive statistics about fear of falling, and I will explain this with you. So on the y-axis, this is the score of fear of falling. Again, it goes from 16 to 64. 64 is the maximum fear of falling the patient could report. And we have here the overall, and then the data divided by the site, Kingston, St. Hyacinthe, Tirana, Manizales, Natal. So I have 2 bars here per site. So the blue is, the solid blue is men, represents men, and the other bar represents women. And very quickly, if you look, you can see that women overall and in every single site reported more fear of falling than men. And this is very important in clinical settings, so you should expect that women report more fear of falling than men, because this has been consistent in all the studies I'm aware of. And I can say that like in the Canadian sites, on average, older adults in this study reported moderate fear of falling. Now, this is the average, keep in mind. In the non-Canadian sites, people reported high fear of falling. So again, the main objective of this study is to see if fear of falling is relevant to mobility disability. So in this graph, we have on the y-axis the percentage who reported mobility disability, and we have two bars for the overall sample and per site. The dark blue represent those with high fear of falling. The light blue represent those with low or no fear of falling. And even without any statistical testing, you can see by eye that those with high fear of falling had much higher, significantly higher mobility disability compared to those with low fear of falling. Now, in the study, we did lots of statistical testing, and the difference between high and low groups was statistically significant and clinically significant, of course. Overall, if you look at the overall sample, those with high fear of falling had about 3 times higher risk of reporting mobility disability compared to those with no or low fear of falling. And this was true across all sites as well, despite the differences between these sites. This is very briefly the first study. After doing this study, we start thinking about not measuring mobility using the traditional way, but measuring mobility as it relates to the surrounding environment. There is an increasing interest in studying mobility as it relates to the surrounding environment, which is referred to usually as life space mobility. And when I say, like, if you think about it, it's not only the physical abilities that determine an elderly person's ability to move around in their communities or go and fulfill their needs outside their homes. Sometimes while you are walking in the streets, you need to go faster, you need to go slower, you need to avoid an obstacle. So it's not only the physical abilities, it's also being able to navigate your community and go out. And this is what people refer to as life space mobility. So in the second study, we wanted to investigate the relationship between fear of falling and life space mobility of community dwelling older adults from 5 diverse sites. Again, I'm using AMIS data in this study. And just a little bit more about life space mobility in case people haven't heard about this measure before. Life space mobility is typically defined as the spatial area a person moves through in daily life. Many studies found that life space mobility, although very relevant to traditional ways of measuring mobility, is a little bit different, and it has been found to be reflective of the individual physical activity status. Like restriction in life space mobility was linked to cognitive impairments, disability, and even mortality. In this study, I will be talking about very briefly. I use a measure called life space mobility assessment that gives the participant a score from 0 to 120. 120 is the maximum life space mobility. So you have unrestricted life space mobility. 0 is completely restricted life space mobility. What I like about this measure, there's a conceptual framework that supports the idea. So they say, like the people who created this measure, they say there are different levels a person could move through. Some people have they are very limited, they are bedridden and very limited to their own room. They don't move outside their room. Some people just move inside their home. Some people go just outside the house, but they don't travel or go outside they don't go to other neighborhoods, for instance. Some people limit themselves to their own neighborhood. Some people limit themselves to their town. And some people can take international trips. They don't have any limitations in their life space. So the questionnaire actually asks questions about all these levels, all these spaces, if I may say. And based on that, gives a score from 0 to 120 that determines the life space mobility. Now, this is not our topic today, so let me go back to our question about the relationship and if fear of falling is associated with life space mobility after adjusting for other factors that could influence the outcome. And yes, the answer was yes, the hypothesis was correct, and fear of falling was significantly relevant to life space mobility. Just to help you interpret this, so with each 1 point increase in the fear of falling, the FESI questionnaire, with each 1 point increase that there's this amount decrease in the life space mobility score. Now, this might not seem a lot, and yes, it is not a lot, but significant and important. And again, so this is for 1 point increase in the Falls Efficacy Scale International Scale. That means if you take someone with maximum fear of falling, let's say, that could be translated into 10% decrease. That could be associated in 10% decrease in life space mobility. Now, the third study, so the first two studies were used cross-sectional data from AMIS 2012. The third study we decided to see, among those who don't have disability at baseline, can we see if fear of falling could predict and is associated with new reported and performance-based disability, functional disability. So the question is to see if fear of falling could be associated with onset of a new disability. And we used two types of measures in this study: self-reported, because there's some in the literature, some literature talking about using self-reported could be more related to fear of falling than performance-based. So we decided to use both types of measures: self-reported, so the patient report their disabilities, and performance-based. So you ask the patient to do like gait speed, etc., balance testing, etc., and you decide if the patient is disabled or not. And again, for the third time in the study, we found that fear of falling is relevant to self-reported mobility disability and performance-based physical disability 2 years later. And that's really very interesting. Just to help reading these data, with each, what this says, with each point increase in the FESI, the tool we used to evaluate fear of falling at baseline, there was 5% increase in the chance of reporting new mobility disability and 6% increase in the chance of reporting physical performance disability. Now, keep in mind, this is adjusting for all other possible confounders. So, like the message here is that fear of falling is highly relevant to mobility, and like here the focus on mobility, but also there are other studies to report fear of falling is relevant to other important health outcomes. And as a physical therapist, usually we focus on like the physical aspects of the patient, muscle strength, balance, range of motion, etc. It's very important to start thinking outside the box and take into consideration these non-traditional factors that could influence mobility, in addition to the balance, muscle strength, etc. Now, I'm not presenting any more data, but the next step in this is the question: if fear of falling is relevant to incident physical disability 2 years later, how that happened? What's the mechanism by which fear of falling could lead to physical disability and functional limitation? And this is a future study we hope to do. I know my friend and colleague Afshin Vivek at Lakehead University is doing a similar study in which he's testing the mediating factors between fear of falling and falls, not disability. I'm not aware about a lot of studies tested this, so this is something hopefully we could do in the future. Now, the last and final section of my presentation is, okay, so we evaluate. I remember like a clinician asked me one time, I was talking about fear of falling, and she said, we evaluate fear of falling, but then not sure what to do with that. And I know this is not an isolated case, so we evaluate fear of falling, and we know this patient has fear of falling. What can we do? There are many interventions reported in the literature, and there is dramatic increase in interest in this field. So if you go and look at the literature, you can see this linear increase in publications about fear of falling, and specifically interventions to address fear of falling. But today I will limit what I share with you here on what I think there's enough evidence to support. And so this is not an exhaustive list. And that's why I'll be talking about two types. So when I look at the literature, I can say that the majority of the evidence-based interventions to improve fear of falling could be divided into two categories: exercise and cognitive-based therapy. So let's start with exercise interventions. If you look at the literature, you can divide the type of exercises have been tested with fear of falling into three main categories. I'm talking here, of course, about exercise interventions: Tai Chi and yoga, balance, coordination, and functional tasks, and strengthening exercises. If you look overall about the durations of frequency and the frequency of the exercise interventions people tested to improve fear of falling, you can see that the majority of interventions have been delivered for less than 12 weeks. And really, this is not a long period of time if we're talking about older adults. Some of them went much more than that, but the majority were delivered for less than 12 weeks. And in terms of frequency per week, the average was the range was 1 to 3 times per week. There's a very nice, very helpful Cochrane review published 2016, and they summarized the evidence about the effectiveness of exercise to improve fear of falling. And they did a meta-analysis, so they pooled the data from individual studies together to come up with one answer, and they found that exercise interventions are associated with a small to moderate reduction in fear of falling in community-dwelling older adults immediately after the end of the intervention. The effect of exercise intervention, so they did some subgroup analysis, and they compared articles, like subgroup of articles based on type, frequency, duration of exercise, and they didn't find really major differences based on the type of the exercise, frequency, or duration. Now, I did mention that the small to moderate reduction was measured immediately after the end of the intervention. For these studies that followed up with patients beyond that, like 6 months and 12 months beyond the intervention, they found that the patients didn't maintain that improvement. Now, this is not a definite conclusion. It might be that few studies only followed up with patients for 6 months or 12 months. But we know, the main message here is that exercise is effective in improving fear of falling. One difference in their subgroup analysis, which I think is interesting, is that the benefit in group-based and community-based exercises were higher than the benefit when compared to the individual exercises and home-based exercises. And if you think about it, this is not surprising. So we have done a different study, not about fear of falling, for hip fracture patients, and we found exactly the same thing. So group-based exercise programs were more effective than individual-based and home-based exercise program. And if you think about it, in a group-based exercise program, you have that social factor. So people support each other, encourage each other. Also, you are able to provide more sophisticated tools to help the patients improve and use the tools in their exercise programs. So this is about exercise interventions. The second category is the cognitive behavioral therapy interventions. And there's also a very good, this is relatively new, systematic review and meta-analysis in which they pooled the data from all individual studies together to see if CBT interventions are effective in improving fear of falling. And yes, it was effective. There's a small effect statistically and clinically important improvement when you use cognitive behavioral therapy. What's interesting about these studies is that the effect, the improvement, was retained up to 12 months post the intervention. And this is a major difference between CBT and exercise interventions. Now, when you look at what kind of CBT they used, you can see that the majority of the CBT interventions included some sort of cognitive restructuring, promotion of physical activities, and goal setting. The CBT interventions ranged from 4 to 20 weeks. It depends on the study you're looking at. Some of them, mainly they used face-to-face interventions. Some of them used phone interview with the patient to deliver the intervention. But the face-to-face sessions ranged from 3 to 9, like the number of them ranged from 3 to 9. In terms of the duration of each session, again, depends on the study, but the range was 20 minutes per session to 2 hours per session. What's interesting, now keep in mind when we talked about exercise interventions, group-based were more effective. Here they found the opposite. So group-based CBT interventions was less effective than, both of them were effective, same thing for the exercise interventions, but the group-based was less effective than the individual-based. And if you think about it, for CBT, you want to tailor your discussion for each individual patient. You want to address the concerns and beliefs of one specific patient, and that's why individual sessions interventions seem to be more effective than group-based interventions. I'm done with my webinar today. I just would like to leave you with some important take-home messages. We spoke about the importance of fear of falling. I see that it seems to be more and more people are measuring fear of falling. Hopefully they are doing something about fear of falling as well in terms of managing fear of falling. It's important, came in the top 10 priorities in that recent paper. It's linked to mobility, it's linked to isolation, it's linked to health-related quality of life. So we need to pay attention to fear of falling. In our studies, we found it's relevant to mobility as measured in different ways, traditional way, the life-based mobility, and it was relevant. Fear of falling was able to predict onset of functional disability 2 years later. If you look at the evidence, there are many evidence out there, and hopefully we will have more papers like RCTs and high-quality evidence to support us in making clinical decisions. But right now, there's enough evidence to say that exercise and CBT interventions have positive effect on fear of falling. Before I finish my presentation and take your questions, I would like to thank our funder, the Canadian Institute of Health Research, and the AMIAS team at the 5 sites. We have a very dedicated team. I don't have time to mention them by names, but they have done a great job in collecting data and providing us with the data to do these studies. Thank you very much, and I'm looking forward to your questions.
Perfect. Thank you very much, Mohammed, for a wonderful presentation and for sharing your extensive knowledge on this topic. We did have a few participants who submitted their questions in the chat box throughout the presentation, so I'm going to address those first. And for everyone else who's on the line and on the web meeting platform, please type your questions into the chat box, and we will read them aloud in sequence for Mohammed to answer. So the first question came from Karen Brown. Does one of the fear of falling scales or measures work better in an acute care setting compared to others?
That's actually a very good question. So the majority of the, as far as I know, the majority of the tools we have right now have been used and validated in community settings. So for community living older adults. So I'm not aware about anyone that has been, up to my knowledge, that has been validated for acute care setting. However, I'm aware about people using fear of falling questionnaires in community settings, and they seem to be functioning just fine. The shorter ones might be better for the acute setting, and perhaps I mentioned that before. I usually, if this is not a specific clinic for falls, if it's general clinical setting, I suggest to start with the one item question, and if there's indications of fear of falling and you want to do something about it, then you go to one of these long questionnaires.
Wonderful. Thank you for that response. Mohammed, I think you may have seen in the chat box, but there were some comments about the second poll question, those who had selected other. There wasn't an option to select that there were no tools or questionnaires that were being used. Some people did say that they created a questionnaire based on the house that their residents were in. Some used observational methods. some used interviews, and some didn't use any at all.
Yeah, very, very fair point. Actually, the second question was intended for those who use fear of falling, but yeah, for next time, I'll make sure to have additional option for those who don't.
Perfect. Thank you. Joanna Walker asked, how could you gather information of fear of falling with someone who has dementia?
That's actually a good question. So the majority, actually all fear of falling are self-reported, and that's something you have to take in mind, to keep in mind. So that's why, like I mentioned in my study, just to be safe, like just to feel comfortable with my data and the results I would have, I excluded those with like cognitive impairment. However, we did look before if any one of these measures have been validated with those with mild cognitive impairment, like borderline cognitive impairment, and yes, so at least I'm aware about the Fall Efficacy Scale International has been validated. There was one study to validate that with mild cognitive impairment. Maybe there are other tools have been validated, but this is the one I used, so that's why I looked it up. But keep in mind, it's self-reported, so having good cognitive abilities is very important.
Perfect, thank you. Tim asked, or rather comments, perhaps subtle disability causes fear of falling, not fear of falling causing disability. Perhaps the fear of falling is real and valid. Do you have any comments about that?
Sure. Well, that's a very real point, and that's why, so in the study, like in the longitudinal study, study number 3 I presented today, we adjusted for baseline functional abilities. One of the concerns that we have that some people are borderline, so they are going to convert to being disabled whether having fear of falling or not. So one way to deal with that, and maybe there are other ways, we adjusted for baseline functional abilities. And we adjusted for functional abilities later on, 2 years later, and that's for this reason. But yes, some people are at the edge, and that might be relevant. However, like one thing, like before we make conclusion, like one thing we have to do is look at the evidence overall. So like the evidence overall are pointing us to that direction. Fear of falling is, now we can't say that fear of falling causes disability, and I usually try to avoid that word, but it's associated with, and with more evidence, at one day we might be able to say with confidence that fear of falling actually causes disability, but very good point.
Great, thank you. Kathy asked, can you comment on whether you would have a higher impact on fear of falling if you combined exercise and CBT, and whether or not they would need to be at the same time?
Very good point, and I'm glad someone asked about that. So, like relatively, this is not a very old field. Like if you remember, like people start talking about fear of falling in the 80s, 90s, and since then the interest. So the time, like interventions takes time, and that's why we don't have all the answers right now as a research community. But I found 2 studies, maybe there are more, but this is what I found. 2 studies combined exercise and CBT, and specifically they used Tai Chi with CBT intervention, and the results are conflicting. So one of them found, so there are 3, if I can give a little bit more details, they used the 3 arms design, RCT, 3 arms RCT. So one group have usual care, one group have CBT or Tai Chi, the other group have both of them. One of these studies found that combining both was more effective. The other one found that having exercise alone, which was Tai Chi, or having exercise, Tai Chi plus CBT, they created some improvement, but there was no difference between these 2 active arms. So, but it makes sense that combining both would be helpful. We need to wait a little bit more until more evidence accumulate about combining them. Personally, I believe yes, why not? But we need to wait a little bit more.
Perfect. Claude comments or is asking why you've concluded that the evidence shows that exercise is effective when the data only showed a small to moderate effectiveness and limited to the duration of the intervention.
Well, that's a very good point. So if you look at rehab interventions in general, they create, so when we talk small to moderate, that's actually the effect size. So there's a standardized measure people use in systematic reviews and meta-analysis. And generally speaking, people say this is moderate, small effect, moderate effect, or high effect. If you look at rehab interventions in general, now there are some exceptions, but in general, rehab interventions, they create a small to moderate effect. And that's why I thought that's typical with exercise interventions. Now, if you are thinking about high, like what kind of interventions could make a huge impact? Usually surgeries. So someone with knee arthritis, they can't walk as a result of pain, they have surgery. After 6 months, there's a huge improvement. With rehab, it's not usually the case, and that's why I think small to moderate is still fine with me. Like, I'm happy with that. And keep in mind, this is a meta-analysis. So they pooled the results from different studies. If you look at the individual studies, some of them had like high impact, like high effect size as a result of using exercise to improve fear falling, but not all of them. So this is after they pool in the meta-analysis, they pool all the results. This is from where I came.
Thank you, Mohammed. We do actually have a number of other questions that are coming in the chat box, which is a great indication of people being engaged with this topic. So thank you, everyone who have submitted questions. But I am being aware of the time, and I can see that many people are logging off. So I will forward these questions to Mohammed, and we'll try to get you those answers as soon as we can. So with respect to time, we will prepare to close down the webinar. Again, I would like to thank our presenter, Mohammed, for a wonderful presentation, and I'd like to thank all of our participants who joined us today and were engaged in such a great discussion. With so many questions, I'm hoping that we can maybe continue this conversation on Loop. And if you want more information about Loop, if you are not a member yet to our fall prevention community of practice, please visit us at fallsloop.com. Just last year, we launched a new online community of practice for children's fall prevention called Loop Junior. So if you have a passion and interest in children's falls, you can also join us at www.jr.fallsloop.com. Please don't close your window just yet. Wait until you have been redirected to the next screen where a brief evaluation survey will launch in your browser. We always appreciate if you could provide feedback so that we can continue to offer high-quality webinars. Thank you so much, all, and have a wonderful day. See you next time.
Thank you very much.